any vaccine had been approved, let alone given to around a third of the population. And so perhaps I can take the opportunity on behalf of the committee and MPs in the House of Commons to put on record our gratitude to both of you personally for your leadership in getting us here, whether it's Sir Patrick's leading role in prioritising vaccine development from the beginning of the pandemic that this committee has heard, and Professor Whitty's role in driving clinical trials in the NHS, including way back in March, driving the recovery trial across the NHS, absolutely crucial to the development of the vaccine. So we're very grateful for that contribution. But turning to the roadmap now, perhaps just to start to understand the relationship between the roadmap and the considerations that you've been making in SAGE. And perhaps to Sir Patrick as Chief Scientific Advisor first, to what extent are the measures in the roadmap reflective of SAGE advice?
The advice that SAGE has given has been around the potential of unlocking to increase cases and how that relates to the vaccine rollout and how that may be minimised. So that's one set of advice that was given. A second, which we've given repeatedly, actually right from very early on, is that outdoors is a lower risk environment than indoors, and therefore in thinking about releasing measures, outdoor things come early if you want to minimise risk. And the third is that of course we have been worried, like lots of other people, about the effects of school closures on children in terms of their mental health, developmental state and educational attainment, and therefore we're supportive of making sure the balance between any risks of opening schools and the risk to children was appropriately reflected. So those are the types of advice that were given. And then one final bit, which I think is really rather important, is in looking at the modelling and the ability to understand what the impact of releasing measures might be, we're cognizant of the fact that we don't really have a very tight handle on the magnitude of impact of different measures. So we can make estimates, but we can't really know. And so it's important to do things both slowly enough and with enough time between steps to be able to measure. And that issue of taking a decision, waiting long enough to see what effect that's had before moving on to a second or a third or a fourth was an important principle that SAGE recommended, and the timing interval was based on an analysis of when we thought data would become available from each move. And that I think is crucial to understand what's happening rather than trying to fly blind on this.
Thank you. And so are you satisfied that the SAGE advice is reflected in the roadmap? Is the roadmap consistent with the advice that SAGE gave?
The roadmap is consistent with those sets of advice that I've just described, which is around timing, of being able to measure between intervals, with broadly going more slowly. We don't give recommendation on exactly how that should be done or which things should be done when, but in terms of the principle of trying to go at a pace that is consistent with the vaccine rollout, so you've got coverage as you begin to release. This is broadly in line with what the modelling suggests is a way to do it that would be better than going fast, and the sort of sequencing, as I said, of opening outdoor things before indoor things, again, is consistent with the advice that SAGE has given.
Thank you. And finally, from me, before I go to my colleagues, are there any then material differences between what SAGE advised and what was included in the roadmap?
Well, I say it follows the principles that we laid out and the way in which we've described that. We don't get into precise details of what happens when and can't. Those are obviously decisions for others to make. So the principles that we laid out have been largely followed in the way the roadmap's been constructed.
Okay, so the advice was principles rather than the specific measures and the timing of those measures.
Yes, SAGE didn't comment on absolutely specific measures. It commented on the principles by which things should happen, gave advice around speed, gave advice around interval between things, and gave advice on the types of things that were lower risk compared to higher risk.
And so those intervals and that speed, as laid out in the roadmap, would you say that is consistent with the speed and pace that SAGE recommended?
Yeah, broadly that is consistent. I mean, certainly the gaps between stages are the ones that we think are the right sort of length, and the broad speed of rollout is one that is consistent with the modelling suggesting the way to minimise the increase in numbers, because it's sort of inevitable that as you start to get mixing going again, you will see an increased spread. I mean, this is how the disease spreads. So there will be increases and pressure on R and pressure on transmission as you open things up. And so what was modelled was a series of different paces of doing that, and the roadmap as laid out was consistent with minimising that increase as you open things up.
Thank you very much indeed. I'm going to go to my colleagues, starting with Dawn Butler, then Graham Stringer.
Very much, Chair, and thank you, Sir Patrick and Professor Whitty, for coming to the committee today. Sir Patrick, would the roadmap be strengthened if we focused more on protection and risk factor rather than policing and complicated messages? Let me just explain that a little bit more. You said just a little while ago that being outside is safer than being inside. So if we focused people's attention more on doing activities outside, or making sure they mitigate their risk, maybe if they get tested and then isolate and then they can go and visit a loved one, for instance, wouldn't that be more sustainable and more effective rather than complicated messages saying on this date you can go and visit a loved one in a care centre, or on this date you can do X, Y and Z?
Well, I completely agree with the premise that actually making sure that we all understand what the principles and reasons behind these things are is important, because I think when we understand things, we're more likely to intuitively adhere to them than if we don't understand them. So I agree with that, and I think making sure that people understand that outside is less risky than inside, that maintaining hand hygiene is important, that making sure that we wear our masks in crowded places. Absolutely agree that testing is important, and importantly, it's not just the testing, it's the self-isolation that goes along with that. All of those are incredibly important ways in which we need to think about controlling this, and some of those need to become ways in which we behave just as a routine part of life. I mean, the more we can make this as a routine around hygiene matters, ventilation and so on, the better this is. In terms of sort of exact dates for things, we've argued, and I think the roadmap reflects this, data not dates, to try and make sure that we understand what the situation is after measures are taken. And then in terms of precise detail, of course, that's for government departments and ministers to work out exactly what needs to be said when, in concert with businesses and schools and other groups that are going to have to actually make very clear preparation for the things that they need to do. So I think the principles bit is crucial, but then how that's translated into policy and operational matters, of course, is for ministers and departments to decide.
Dawn?
There seems to be a lot of dates which doesn't relate to data. And my last question, please, Chair, is in the UK, we've changed the regulations regarding the tweaking of vaccines for fast-track approval. And I understand that in regards to the various variants, and internationally, you know, there is real concern, and they're calling them scariants now rather than variants. Does it pose any risk to patient safety?
Sorry, does what pose a risk to patient safety?
The changes that we've made in the regulations. So the tweaking of the vaccines that we've asked the scientists to do in regards to combating the different variants, they're not going to go through the same process as they originally did. It's been fast-tracked. Does that in any way risk safety of patients?
So the way vaccine approval works, and it's worth thinking about this in relation to flu vaccine, every year the flu vaccine gets modified, and it gets modified when the scientists start to look at how flu virus itself has changed over the year, what's happened in the southern hemisphere, what's happened in the northern hemisphere, and so on, and make predictions as to what the new vaccine should look like every year. And that process is one of adjusting the vaccine, but built on the same backbone as the vaccine from the previous year. So the sort of, if you like, the heavy lifting bit of the vaccine is the same year on year, and then bits are changed in order to make it relevant to the flu that comes that year. So that's the process, which is very well established over many years. And in essence, what the argument is around coronavirus vaccine is the basic vaccine backbones have now been approved and looked at, some of them anyway, the ones that are in use now have been approved. And if you tweak then one part of that in order to make it more likely to tackle a variant, and that hasn't been done yet, people are looking at that now, but if you're doing that and you don't change the rest of it, it sort of falls into a flu-like category of a now vaccine which is broadly the same but changed. And then it's up to the regulators, and this is obviously why we have an independent regulator, and that regulator needs to make decisions as to whether the changes are such that broadly this looks like the same vaccine tweaked a bit and therefore has the same safety profile, or whether the changes are more substantial than that, and you need to go through other things. So that's a role for the regulator.
Thank you. Professor Whitty, have you got anything to add?
Not on that.
Okay.
Great.
Thank you very much.
Thank you very much. Thank you.
John, we'll come back to you a bit later on, but Graham Stringham now.
Professor Vallance, is Data Not Dates, is it anything more than a slogan?
Well, for us, it's not. I mean, for us, it's very important that you measure what you've done. And we don't know what the impact of, for example, schools going back is going to be. And so there's an estimate from the modelling group that it could have an effect on R between 10 and 50% increase. We don't know within that range exactly what it will be. We know that as contacts increase, transmission increases, and we know that as schools go back, other things happen as well. Parents meet, people who perhaps weren't going into work, some of them may go into work as a result. So it changes a number of things, all of which may have pressure on transmission. That's why, from the perspective of our advice, it was to make sure that you really have enough time to measure what has happened in response to each change, and then decide whether you've got room to make the next change, either on the date that's been announced or delaying if you have to. So I think nobody would say that we know exactly how this is going to roll out over the next few months. And the important thing is to measure, adapt, and take decisions in the light of information as it emerges.
I understand that, although Professor Woolhouse told us a few weeks ago there'd been no surge when schools had opened in this country and in other parts of the world. There'd been no surge in increased infections. What I was really getting at is what are the numbers, what are the thresholds that we would know that it is working or not? What is it, the number of people that are being admitted to intensive care? Is it the number of people who are dying? Is it the R number? Is it the infection rate? What are the numbers that we will enable us to judge whether the policies that have been taken are successful? Because if we don't know those numbers, surely it is just a slogan.
I think ministers have set out the 4 tests that they wish to use.
But they're number 3, aren't they?
Sorry?
They don't have numbers in them.
No, well, those are the tests that the ministers wish to use in order to make decisions. What we will do is feed in the numbers as we see them in terms of cases, hospitalisations, intensive care, deaths as they occur during that period, and trends that we see within that. So that's where we will input into the information that ministers have when they wish to make decisions.
But there is no way that members of Parliament, as being outside this process, can look at the numbers that are being published and say, this is really successful, or is not going as well as we wished it was, so that we can judge it. It is just a debate between you and the government that allows arbitrary decisions to be made, isn't it?
We will make all of our data public as we always do. We will make our interpretation of that available as we always do. So that will be a source of information for people to look at.
I'm sorry to interrupt. I don't like interrupting, but I accept that the data in these occasions will be made public. But it is when that data is made public that we can say this is going very badly because there are so many people going into intensive care or whatever the criterion is. But you're not telling us either what you're advising the government the criteria should be, and what the government will take it. We've got general principles, which is difficult to disagree with, but I want to know what the threshold, what the critical numbers are.
Well, those are issues for ministers to decide what they wish to have as targets for these things. They're not matters for science to determine. And we can give the information, and we can give the trajectory, and we can give the impact that we think has happened as a result of the changes that have been taken. Obviously, it is a matter for ministers and Parliament to decide what level of risk and what level of events people are prepared to tolerate.
I'm labouring this point, but it's the last time I'll ask the question in a different way. So you haven't recommended precise figures to the government that will trigger either them to go faster or, in more likelihood, go slower?
We haven't recommended precise numbers. No.
So it's, in my opinion, it's a slogan. Can I move on to Professor Whitty? There are a number of uncertainties which have been discussed and the direction it's going in. One of the things I don't understand is in terms of the vaccination programme, which is going extraordinarily well, and is a credit to everybody who is involved in it. Most of the over 70s, soon over 60s, will have been vaccinated. 90% of the deaths are those come to those people who are in the top age group, over 80, or who have other conditions. Yet the modelling is saying 30,000 people are going to die. How can you explain that figure when the vaccination programme is so successful in covering those people?
Thank you. The vaccination programme is very successful, and you're absolutely right, it's a huge tribute to everybody who's been involved in it. But the vaccination programme it protects people essentially in three ways. The first of which is it protects the individual vaccinated. And you must remember that of those people who have been vaccinated, the great majority of them have only been vaccinated once. Now that provides the majority of the protection, but not all of the protection. The second, so they need to have a second vaccination to get the full benefit of the vaccines that have been deployed. They're both two vaccines. The second protection is the people who they meet being vaccinated, and that is partially achieved in people, for example, who are living in care homes or nursing homes because of a vaccination programme among their staff, but it isn't necessarily amongst everybody else. And other people they might come across, and certainly people who are out and about, going to shops and so on, will come across many people who are not vaccinated. And then the third way is in which it helps to reduce the overall rate, because the probability that an individual person who's vulnerable will meet a virus is essentially the overall rate in the general community. But even when people are fully vaccinated, a significant minority, it's not large, but a significant minority do go on to get significant disease. It's not zero. There are some vaccines which are as close as means no difference to 100% effective. These are not those vaccines. They are extremely good, but they're not at that level. And we don't know who those people are. And then there are some people who have chosen not to, or have not been able to be vaccinated, who are also at risk. And finally, there are people who are at risk in the lower age groups. So the modelling is just reflecting the fact that because this is such a common virus and it gets to large numbers of people, even if you have a relatively small proportion of people still remaining vulnerable, that still equates to a very large number of people overall. And that's really what this is reflecting. And I think what we're going to see is, as things are opening up, what all the modelling suggests is at some point we will get a surge in virus. And whether that happens, we hope it doesn't happen soon, but it might, for example, happen later in the summer if we open up gradually, or if there's a seasonal effect, it might happen over the next autumn and winter. But I think all the modelling suggests there is going to be a further surge, and that will find the people who either have not been vaccinated or where the vaccine's not worked. And some of them will end up in hospital, and sadly some of them will go on to die. And that's just the reality of where we are with the current vaccination. The current modelling does make a number of assumptions. Go into those in detail as to if you're interested, but broadly that is the reason why we're expecting to see further deaths, although the ratio of cases to deaths will go right down as a result of vaccination, but not right down to zero, unfortunately.
I accept that. What is 30,000 as a percentage of those of the group of people who are most likely to die if infected?
Sorry, I don't understand the question.
No, the thrust of I find the figure of 30,000 when a large percentage of the most vulnerable population will have been vaccinated, a difficult figure to arrive at, to understand how it is arrived at. And if the country is vaccinated, most of the group or groups who are likely to die, the over 80s, those people with other conditions, they are 90-odd% vaccinated. What is 30,000 as a percentage of the non-vaccinated? That must be a serious part of the calculation to work out who is likely to die.
Well, the difficulty with working out who is likely to die is that there are several different groups who potentially are going to die, some of whom we cannot identify in any way. You're absolutely right that the great majority of people who die will be either older or have pre-existing health conditions, but not all. But the great majority, you're absolutely right, obviously. And secondly, we don't know of the people who've been vaccinated who it is that the vaccines have worked in and who it has not. But we know that there will be a minority who won't. Now, I would not get too stuck on individual numbers. I've repeatedly said all the way through this pandemic, forward projections of exact numbers are really difficult to interpret, and I really put huge confidence intervals around them. The general point, though, is this is not just a few people. These would be significant numbers of people who are dying, just as in any given flu year, an average flu year, 7,000 to 9,000 people would die, and in a typically bad flu year, over 20,000 people a year die. These are not ridiculous numbers. They are perfectly reasonable numbers for a significant respiratory virus that is infecting very vulnerable citizens, even when vaccinated, as they may well have been, for example, with flu.
I was just trying to get to the basis of that number. Thank you.
Thank you, Graham. Just to pursue Graham's point a little bit, Professor Whitty. Obviously, the modelling is based on assumptions, or models are. The principal models that have gone into this include the Imperial College model and the Warwick model. And the assumptions on, for example, the efficacy of the vaccines have happily been superseded. They're better. And so has the take-up, has it not? So to Graham's point about the 30,000, that 30,000 presumably comes from those who either haven't been vaccinated or for whom the vaccine has not been effective. But actually we know, happily, that that group is much smaller than modelers with the best information they had at the time had predicted. So does that cause you to revise your view as to what we should be preparing for the summer?
Well, I think that, there are probably several points I'd make on that, if I may, Chair. I mean, the first of which is, to repeat my previous point, I think zeroing in on particular numbers, every single number will be incorrect. What they're doing is they're giving an indication of general principles. And the first and most important principle that the models demonstrate is if you open up too fast, a lot more people die. A lot more people die. So the main point, I would say, of the modelling is to demonstrate the really profound difference between opening up too quickly, which leads to very large numbers of deaths, and opening up more slowly, in a steady way, in the way that Sir Patrick was describing early on and is laid out in the roadmap, which doesn't lead to no deaths. And I think it is really important that we do not give any impression that what we're expecting is this just goes away and there's no further deaths. That is not realistic, and I think to pretend that to the British public would be completely wrong. It isn't the case. There will be further deaths. But by going steadily, what the models demonstrate is you will have many fewer deaths. Now that depends on the fact that the vaccines are coming in to do a very large amount of the heavy lifting. And I very much hope that because the vaccine uptake is so far is good, and it is very good, but this is an older population and vaccine hesitancy is slightly different from different ages, might want to come back to that. So far is good, and the vaccine effectiveness does so far look at the higher end of the expected range, but not way out of the ballpark. This is a bit better than the central projection. But if you recall from those Warwick models, because I know you've looked at this in detail, they actually did an analysis looking at a 99% effective vaccine and still saw significant numbers of deaths. So the idea that this completely takes it out of scope, I think, is probably not correct. But what you do see with the modelling is that if you do things steadily, you get a much lower and shallower peak. Unfortunately, there still will be a surge with significant numbers, but much fewer deaths. And it's pushed further back in time. There is, in my view, and this is not in the models, likely to be some degree of seasonality, which I think will push the peak a bit further back in time. It doesn't get rid of it, it moves it in time, it doesn't eliminate it. But what we hope is that by the time we get to the point the peak is really happening, if we go steadily enough, a very high proportion, ideally all of the adult population, will have had at least one vaccine. So we'll have some high degree of protection. But to go back to the first point, this is not a 100% effective vaccine, even for those who take it, which of course at the moment is the great majority.
Indeed, but the essential point is that even though the effectiveness of the vaccines and the take-up has been higher than expected so far, that doesn't cause you to change the advice as to the pace of unlocking. That's the point you're making, is it?
No, it definitely would not. Under all scenarios, if we unlock very suddenly or even significantly faster than is recommended, all the modelling would suggest that we would get a substantial surge whilst a lot of people are not protected. And remember that the people who drive the wave of infection are not generally older citizens, it's generally younger ones. So the vaccination policy that we've taken at the moment in the UK, which is absolutely to go through the highest risk people first, will really seriously reduce the ratio between numbers of infections and deaths, and that's a fantastic achievement. But it will have a much smaller effect on the actual drive of the wave of transmission, which tends to be in younger adults. And they have not yet been vaccinated, and therefore vaccination will have almost no role to play in reducing transmission in that group for some time, because we haven't yet got to the point those are vaccinated. So if you released very quickly, you'd suddenly get a wave of transmission through younger adults, and that would lead in due course to older adults being infected, and some of them, either because they hadn't had the vaccine or because they weren't fully protected by the vaccine, would go on to get serious outcomes.
Thank you. Just before I bring Aaron Bell in on this point and then Dawn Butler back, Data clearly has been elevated to have great importance. It was Angela McLean that told this committee that data, not dates, was the approach to take. The roadmap does have a lot of dates. 8th of March, yesterday, schools reopening, 29th of March, outdoor sport, 12th of April, outdoor pubs and cafes, 17th of May, indoor hospitality, 21st of June, weddings without limits. So there are a lot of dates there. If we're to be driven by data, does it follow that if the data is better than anticipated, then we can bring forward some of those reopenings?
Well, I think what Sir Patrick laid out at the beginning was the fundamental reason for having the particular 5-week gaps between each of the stages. The reason is that it takes at least 3 weeks, possibly 4, to get the data and to analyse it properly. And remembering there is at least a sort of 10-day lag before you even start to see cases coming through. And the Prime Minister and ministers have said they want to give people a week's notice before major changes are taken, so that people can make proper preparations either way and don't have to do handbrake turns or sudden starts from absolutely nowhere. So if you do that, then you're not going to want to reduce the time between the various steps. And then if you look at the steps, each one of the steps is actually quite a big step. So this first step, opening all of schools, and that's a lot of things, plus some other areas to be opened up. And that includes the decision for people to meet outdoors, much lower risk, as Sir Patrick was saying at the beginning, but not zero risk. So step 1 is already quite a big step. Step 2, if you look at the list of things that are in that, is a very long list of things. All the high contact things indoors, gyms, retail, very long list of things. Again, a very significant step. You would want to see what the combination of schools plus all of those being open is, and that takes you to another 5 weeks. And then you get another very significant step. Really, the last step is probably the smallest in one sense step, but even that has, which is taking all restrictions away, you would want to be absolutely confident that we were safe to do this. And I think a lot of people may think that this is all over. I would encourage them to look at what is happening in continental Europe at the moment, where a lot of countries are going back into rates going up and having to close things down again, having not been in that situation before. And I think it's very easy to forget quite how quickly things can turn bad if you don't keep a very close eye on it. And if I can just give one historical point, I know it's not a looking back thing, but I think this illustrates the point. If you look back to, we looked at the data from yesterday, which is the data we have, 65 deaths, a low rate because it was from Sunday, but excellent that things are going down. We feel very pleased that's going the right way. If we look the same date a year ago, so from the 8th of March, there had been in total 2 deaths in the UK. And by the 23rd of March, we were in lockdown in a very difficult situation. So I think people just should remember that things can turn bad very fast if you don't keep a very close eye on what's going on. So I think that's the reason for taking the steps of 5 weeks for a logical reason, which is around when you can analyse the data. And the size of the steps are each already quite large. And you would really want to be very careful before you loaded still more on each of the steps before you were sure what effect that was going to have.
It's important to look back and it's important to look at other countries, but it's also important to take account of changes that happen, and the big change is the vaccine. And the striking comparison between this country and other European countries that are having to go back into lockdowns is that we have a much more effective vaccine rollout programme, is it not?
Well, I think to go back to my previous point, if you're thinking about a surge in transmission, remember that the great majority of those who will drive a surge in transmission are not yet vaccinated and will not be vaccinated by Easter. So I think the idea that that is a sort of get out of jail card in terms of a surge of transmission, I think is to misremember where in the age spectrum the drive of transmission is. And it's in younger adults, not in those who have so far been vaccinated by and large. Now, of course, the further down the age range we go, the higher the percentage of the population are vaccinated, and particularly when people have had 2 vaccines and a further 10 days or so after the second vaccine, of course that's going to take more and more of the heavy lifting. And that's the whole point that the modelling shows, which is if you take things steadily and then start your proper opening up, really the biggest risk opening up, when a lot of the people in the lower ages have been vaccinated, then you're in a much better position. But if you start shunting things forward, you will very quickly get to these very high peaks that were there. And I think that's for quite, you don't need modelling to understand that the big drive in transmission tends to be in adults under the age of 60. And at the moment, we're only just getting to those who are in their 50s, other than those who've got pre-existing health conditions.
The timing of these measures is clearly of great importance, and this is why all of us are pursuing this, because it's on the minds of members of Parliament, because it's on the minds of our constituents whose jobs depend on this. So just to kind of explore this a bit further, so Professor Andrew Hayward, who we know of University College London, said absolutely right to be driven by the data, but if we're driven by the data, then we need to be prepared, if things are better than expected, that we may be able to release faster than we expect. That is reasonable, isn't it?
Well, I think Andrew would probably want to consider what he meant by faster. I don't think he would at all suggest that we should concertina the 5-week gaps, because that is, if you're giving a week's notice to people, that is the minimum period you're actually going to be able to have data to be able to look at and take a serious judgment. So I think in terms of how long the period between steps are, I think that is a significant. You want to be quite careful. Now let me just read out what is going to happen on the 12th of April. So we're going to have indoor leisure, including gyms and things, libraries, community centres, personal care, retail, outdoor hospitality, lots of things around children, domestic stays overnight, including self-contained, etc. There's a long list of things that are being opened, and you would want to see how all of that opening, which is a lot, and I don't think Andrew would be arguing we should be doing more than that at that stage, interacts with schools, which are now completely open by that stage and back by the time we get to 12th April, we're going into the summer term. And so, what we've got is actually quite large blocks of potential risk altogether. And I think actually when you look at that, you'd think, well, what would you want to put on top of that? Given that if we, what the government has been told over and again is take this steady, and what we don't want to do is accelerate into trouble and then have to reverse straight back out again, open things up and immediately close them down. That is not what anyone's asking for. So what we should be trying to do is sticking to the 5-week period, because that's when the data happens, and making sure what we have is sensible blocks. And if ministers want to relook at this, of course they can. But if you just think about what's all being opened in April, and exactly the same is true in May, a very substantial block of things with very high risk when you put them together, I think you'd really want to think quite carefully before you load even more onto that. If you're trying to reduce to an absolute minimum the risk, you then have to reverse out of it.
But if we got, say, to the end of April, 6 weeks' time, more or less, and the levels of infection, admissions to hospital, pressure on hospitals, the ability of the knowledge of the vaccine and its efficaciousness against new variants, all of these things had gone very well, would we still need to wait until the 21st of June just because we had set a date rather than be guided by the data?
Well, the point about the dates, to go back to the dates, is that the dates are set by when you can measure the data. So in a sense, my view is you should take the dates as fixed. The question about what's in the dates, there is some question that ministers could look at. But if you look at the history of this all around the world, the history of this is not full of countries and individual leaders wishing they had done more faster. It's full of leaders who wish they'd actually acted quicker and then be more careful as they take things off. That is the history of this everywhere in the world. This is not specific to the UK at all. And so I think, given what large blocks you got in those periods, and if you accept the logic that you should be driven by data, in which case the 5 weeks is basically the minimum you can talk about, I think you really would need to think quite carefully before, for example, you took some of the really major indoor risks and pushed them into the middle of April, when you still have not got a great majority of the population who are at risk, double vaccinated, and you've already taken a lot of other areas which have got potential risk associated with them. So I think, my view is ministers are trying to take this steadily. They're trying to do it based on data. They're doing it in big blocks. These are big blocks of risk taken together, and then waiting long enough to see what's happened so they can make a sensible data-based judgment about what the next step is.
Okay, Aaron Bell.
Thank you, Chair. Thank you both for your time today and everything you've done throughout the pandemic. Just to continue on the line the Chair's been taking, I think data not dates is something this whole committee can get behind, but with our interest in science. But it's 104 days until the 21st of June, and I understand your natural caution, but the lesson from last year is obviously not just that things can turn bad quickly, but that the idea of predicting the path of the virus 100 days ahead seems to be something of a fool's errand. We're told there'll be a doubling supply of vaccine from next week. I'm 41, I should be getting my first jab sometime in the middle of next month, I expect. And you both understand too the damage lockdown's doing, not just economically, but to people's mental health and all the other pressures that have been on the NHS. So, I understand your natural caution, but are we really saying that 21st of June date is set in stone and there's no way that we could possibly go quicker? I think the 12th of April date needs to be set in stone as the first review date, but if at that review date we conclude things are going better than expected, surely there's a case for bringing those other steps forward a little bit. Professor Whitty first and then Sir Patrick.
Well, starting with the obvious point that these decisions are ultimately absolutely for ministers, so it's not for me to say exactly what should be, but I think there are two things that I would strongly advise based on principles, and this is going back to Patrick's point. Our job is primarily to give principles, the first of which is do not try and concertina up the 5-week breaks, because if you want to be based on data, you're going to have to use those 5 weeks if you wish to give people a week's notice. There isn't time, you simply can't see the effect size any time that's shorter than that. And secondly, each of the blocks you're looking at, yesterday's one, which I think we're all delighted about, schools going back, absolutely critical for children's long-term development, mental health, all health and other benefits of schooling, everyone doesn't contest at all. That's a big block added to some additional things which allow people to meet outdoors, which is again, something which people really, really want. The 12th of April block is a very big block. If you look at all the things in the 12th of April block, they're a big block. You're going to want to wait and see what that does. And then the 17th of May one is a very significant block with a lot of stuff that's indoors for the first time. That's the point when we're really going to start to see some very significant risks accumulating potentially. You really, if you're wanting to be based on data, I think that seems a reasonable way to go. Now, that's not my, it's absolutely not my role to say exactly what should be in which of those blocks, but the principle that those blocks should be manageable size whilst significant, which they are, and 5 weeks apart, I think is one that has got a very sound logic behind it.
Okay, just before I turn to Sir Patrick, the 4 week, you're suggesting that we need 4 weeks before we can, that would be the earliest point at which we can see the impacts of the previous step, and then the week the government says they want for announcement. I mean, surely there must be some indicative data that comes in after week 2 and week 3, or are you saying, through cases? Obviously, we realise there's a lag between cases and hospitalisations and deaths. There has been throughout. Is there nothing we can pick up earlier than the 4 week point that could be useful in terms of potentially shortening that gap between steps?
Well, if you think about the actual way in which you can pick stuff up, you're not going to see anything for a generation time and probably 2 generations time. It'll just be completely impossible to see at all. And then you've got to have enough of a direction of travel that you can actually see the slope in a way that you feel the constant intervals are narrow enough you can actually say something useful from it. Now, are you, on the basis, even after 4 weeks, actually, were you the minister, would you feel confident of putting a bit forward because it seemed initially a popular thing to do, and then being in a situation you've overloaded the system and actually you have to reverse and actually start closing stuff down again? I suspect you would view that as something which people are not asking for when you think it through. It's really about, do you have enough information? What the period of time will allow us to do is have a rough view as to whether this looks as this is going way out of the path that we were expecting it to go in which case ministers can be advised that these data do not look good. It's pretty doubtful you're going to be in a position where you'll be able to say these data look so fantastically better, please take more risks here. I think that seems a very unlikely situation, given how large these blocks of activity already are. But clearly, at the end of the day, it is a decision for ministers.
Thank you. Did Sir Patrick want to add anything on those points, or shall we move on?
Well, I agree with the way Chris has expressed it. I mean, if you think about it, when you make a block of opening up, you don't get an instant change in infection. You start to see spreads as people begin to get increased contacts. That takes time for that infection spread to be detectable. You will have, as you will have seen, as you follow the data closely, I know, you will see you get bumps in the road. You think, oh, it's going in the right direction. No, it's not. It's going in the wrong direction. So we will see ups and downs during that period. It takes even longer to then start to see, well, what's that translating to in terms of hospitalisations? Quite an important distinction in the presence of vaccines, because vaccines are going to have a bigger effect there than they are on transmission, particularly as transmission is largely going to be occurring in the unvaccinated group, as it always does at the younger age groups. So the estimate is that after 3 weeks, you can start to get a real handle on this, and it's probably somewhere between 3 and 4 weeks to really get a decent handle on what's happening. And then it's the week that the ministers want to be able to alert businesses and others to what's going to happen. I think if you truncate that, you are essentially flying blind. You might feel, oh, I can smell it going in a certain direction, it looks like this, but you really won't know. So that is what the basis of that gap is. And then, as Chris has said, there are quite a large number of things in each block, and we simply can't measure now what effect that's going to have. The more you put in there, obviously, the higher the risk, and that's a decision for others to determine what goes in there. But the principles of saying, let's get the schools open, then let's go for outdoor, then let's go for indoor, seems like an entirely sensible one in terms of the risk profile and the ability to measure the effect.
Thank you very much indeed. Can we go to back to Dawn Butler, and then Rebecca Long-Bailey, then Zara Sultana?
Thank you, Chair. A couple of quick questions. I mean, it is quite obvious that a lot of what the government's doing, data, not data, rather than the other way round. But I want to just take us to the effects of the coronavirus. We know that it affects African Caribbean, Asia, minority ethnic people more than others. What advice have you given the government to mitigate this, please? Professor Whitty?
Thank you. I mean, you do raise an extremely important point. I think what we need to do is divide the risk that has led to higher, significantly higher rates in some cases in many of the ethnic minority population groups of the UK into the risks of getting the infection, and then once acquired, the risk of dying or having other severe side effects or long-term problems of the infection. Those are separate sets of problems, and they have slightly different mitigations. In terms of the risk of acquiring the infection, this has varied very significantly as you go through the pandemic. And in the first epidemic wave, the biggest groups affected, the biggest group in particular, were people of British Black, Caribbean, Black African heritage, but also significant numbers of people of South Asian heritage and other ethnic groups as well. Then if you look at the first wave, part of the second wave, before we got to the B117 period, when there was a lot of transmission in the Midlands, a really heavy emphasis and unfortunately effect on people of British Pakistani heritage and British Bangladeshi heritage, really almost no additional risk to people of British Afro-Caribbean and African heritage. And that was largely to do with where in the country the wave was. It was in the Midlands area, and the pattern of different groups was that was the bit of the country which was hit, and therefore ethnic minority groups who were highly represented in those parts of the country were very highly represented, unfortunately, in the people who had serious problems. And then in the second half of the second wave, what we're on the downslope of at the moment, back to, because there was a lot of transmission in London, back to a situation where it was more reflective of the London population. Now, the reason I'm making this point is that it's quite a complex picture that we're seeing in terms of acquisition. And a lot of it is to do with occupations. Many people in many of the ethnic minority groups are in high-risk occupations. They might be in caring occupations. They might be, for example, taxi drivers or security guards, which we know are high-risk groups. So some of it's occupational. Some of it's maybe to do with family structure in terms of, for example, multi-generational households. We think that was very significant in the effect on, for example, people of South Asian heritage in the Midlands area with multi-generational households. Some of it is undoubtedly the broad group of things that can be talked about, all the disadvantages of deprivation. Now, there's clearly not an absolute correlation here, but where people are living in deprived areas, that, as with all infectious diseases pretty well, that is where COVID has concentrated. There's a really strong socioeconomic gradient and a really strong urban gradient. So higher rates in urban areas than in rural areas virtually everywhere. So it's a combination of factors. Now, some of those are things which the main thing you can do is to try and make sure, and then finally, and this is the final bit of disadvantage, unfortunately, when we come to acquisition, and this is a future problem, which we really, really must get on top of, and I'm doing a lot of thinking about, as everyone is some of the ethnic minority groups have lower vaccine uptake and greater vaccine hesitancy for a whole variety of fully understandable reasons, but that is an observable fact. People, particularly of African heritage, that is the case in the UK. Well, it's getting better at the moment. The direction of travel is better. And then there's a second group of problems which are more biological, which are once someone's acquired it, what's the chance of dying? And that's to do with things like diabetes and comorbidities and a variety of other factors, which are much more, in a sense, in the medical sphere. Now, the medical sphere is more straightforward in one sense, because doctors, nurses, other health professionals have to deal with that directly as they come, but there's no doubt that there's a difference in the pattern we've seen in severity in some ethnic groups. On the first one, it's very much about concentrating efforts as far as we can in areas of deprivation and in those professions which are at highest risk. And that has been the most important thing, because, and if we do that, we're going to reduce some, but not all, of the ethnic disparities, and also reduce some, but not all, of the socioeconomic disparities. But the problem, of course, is many of these disparities are very, very deep-rooted. They're not things you can just magic away in a very short period. They are really fundamental problems, and really fundamental problems for the long-term health of these citizens. This is not just a COVID problem. This is an overall problem.
Absolutely, it's very much structural, Professor Whitty. I agree with that point. And does the government understand that structural inequalities?
No, the government does understand it. I think that the problem with many these long-term structural things is they're much easier to understand than just to sort in a short time. But they're things that need sorting out fundamentally, and they are all the things that lead to deprivation and all the ill health that goes with this. And this is, if you're in public health, which I am, what you have to do is think about deprivation the whole time, because so much of ill health, not just COVID. COVID is in a sense, a really extreme current example, but the same would be true about diabetes, the same would be true about cardiovascular disease, same true about very, very many other areas. And we really, you have to think about that in all aspects of health, as well as wider disadvantage.
So fighting for more investment in those deprived areas will help with better health outcomes.
Well, I think improving all the environments where people live in areas of deprivation will help not just health outcomes, but life outcomes. And that's
housing, jobs.
all these things. And I think this is not a controversial statement. It's a simple statement of fact that these are critical issues across the board. Of course, they have a major health impact, which is why people like me are obviously in very strong engagement. But they have impacts on everything else as well: life chances, education, all the other areas as well.
Great. Thank you very much. Thank you, Chair.
Thank you, Dawn. Rebecca Long-Bailey, then Zara Sultana.
Thank you, and thank you, Sir Patrick and Professor Whitty, for your relentless hard work and for coming along today to speak to us. Now, the Sage 80 minutes on the 11th of February state quite clearly at point 57 that the consensus view remains that the opening of primary and secondary schools is likely to increase effective R by a factor of 1.1 to 1.5, and at point 60 that there are a number of uncertainties in the modelling, including the potential network implications of reopening schools. A phased reopening would allow the effects to be assessed. So with this in mind, and in the context that it was undeniable that infection rates began to increase significantly when schools reopened in September, can I ask you both, for the avoidance of doubt, was the government advised by SAGE to pursue a phased reopening in March? And more broadly, what are the implications of not following this proposal as set out in the SAGE minutes? Professor Whitty first.
Well, actually, I'm going to unfairly slide this to Sir Patrick, only because he's the main chair of SAGE, and if he wants to send it back to me, I will happily answer it. But
Sir Patrick,
okay, great.
Drawn the short straw.
No, I'm very happy to answer this. I mean, SAGE has looked, as I said, at the potential implications of opening schools, and because of all of the other things that go along with that, including increased parental mixing, potentially people taking different work patterns and so on as a result of this, it's quite difficult to know precisely what the effect is. And that's why they come up with a figure of between 10 and 50% increase. And we don't know where it's going to be on that spectrum. They also modelled a sort of staggered opening versus a single opening, and essentially you end up in the same place. You just end up in a different route to get there. So you don't overall have a different impact on that. But of course, the less you do, the less the effect initially. Now, the question for decision makers there is, if you went sequentially in opening up, you then have to put a 5-week gap between all of this. You'd be a very long time before you got to a complete opening up. If you go immediately, then obviously you can have a bigger effect. I don't think there's any doubt about that. And you'll have to measure that after 5 weeks and see where you are. Where we are now is schools going back altogether. There's then a holiday, of course, with the Easter break, a chance to find out what the effect of that will be. And then to go back to, I think, the point that Graham Stringer raised earlier on, when we look back at the impact of schools opening, in general, schools seem to reflect quite closely what's happening in the community. So although we know spread occurs in schools, and we know that children can of course catch this, and we know they're not at increased risk personally in the same way as older people are, and we know that can be brought back into the household from schools, because that does happen, it still looks like the way in which schools impact in this is largely as a reflection on community spread rather than as a driver. Now, it may be different in the current situation because there are some of the few things open now, so that may be a place where we do see driving. So all of these things we don't know, we need to measure, but our advice was, as laid out in that paper, that we expect there to be an effect on R, and it's absolutely essential to measure it, and that staggering an opening will lead to the same ultimate effect as opening altogether. Chris?
Can I add to that, because I don't want anyone to feel I was sliding that question because I didn't want to answer it. I just thought, since the question was about SAGE, it was right that Patrick had first go. Let's start off. I mean, I think there are broadly four important groups to think about when we're thinking about the school opening decisions. There's children. There's the wider effect on R and society, which is what Patrick's just talked about. There's parents and there's teachers, and all of those are really critical groups. Now, in the case of children, I think everybody who's looked at this pretty well is unambiguous about the advantages of education for children on their physical health, mental health, obviously long-term prospects. And actually, to go back to the last question that I was asked, about this is one of the most powerful drivers of reducing disparities between different groups. So if you don't have children in school, you are doing them a significant disservice. And I don't think anyone disputes that. I think that's a really clear thing, whether it's health or long-term prospects. Set against that, the risk to children from COVID is extremely small. It's not zero, but it's extremely small relative to adults. Smaller, in fact, than for seasonal flu. And therefore, from a child's point of view, and we should always start with children, the risk-benefit is clearly in favour of education. Now, the next group, obviously, to think about is the point that Patrick just made on the R. I haven't got a huge amount to add on that, except that, we're going to have to open schools at some point, and having this block all about education, given that the next block is also a very large block, makes a lot of sense. And I think we'll just have to, we've got the 5 weeks, we've got the Easter break, potentially. So I think people can exaggerate the risk of doing this, given that there's actually a natural fire break around the Easter break on the R side.
Rebecca.
The third area is, sorry.
Yeah, sorry, Professor, carry on.
The third issue is around parents, and I think that there is a little bit of introduction from schools into parents. A lot of it goes actually the other way. But as Patrick says, what drives transmission in schools, as far as we can see, is actually what happens in the general community. That's the kind of the big driver. So the way to protect schools is to keep the rates of transmission down, which is why so much of the rest of society keeping the rates down, and everyone's been absolutely fantastic at doing that. And finally, of course, teachers are concerned, and that's perfectly legitimate. The risks to teachers are not in the very high risk groups. All work that is not from home is a slightly higher risk. That's the reason that, among others, we recommend people work from home where they can. But that is, that is a relatively not in the kind of group like, for example, social care workers and others who are in those kind of very high contact groups. And we are hoping that as vaccination is rolled out, that is also going to move them the highest risk teachers also are protected by vaccination. But that's an important thing just to acknowledge. But in terms of the things of the R side, which is where you started off, I think, as Patrick says, it's either a problem now and we wait, we've got the holidays and then we measure it, or it's a staggered problem, but it's still the same problem.
Thank you. Rebecca?
Thank you. So firstly, to be clear, SAGE didn't advise a phased reopening. I think a yes or no answer would be very helpful, because I think the public is certainly confused. And secondly, just to draw on some of the points you made, in the same paper, the SAGE 80 minutes, at point 53, a varying selection of mitigation measures were suggested, one of which, very important, included social distancing, which isn't viable in most school settings. It simply isn't viable. How would that change the responses that you've just given? So firstly, have SAGE advised for a phased reopening, yes or no? And secondly, how will the fact that social distancing is nigh on impossible affect the responses you've just given? Thank you. Firstly, Sir Patrick.
Well, SAGE laid out the evidence as you've seen it, and said that here are the options that you have to take. You can take an option to go all in one go, or you can take a staggered option. You end up in the same place over a different time frame. So we didn't say this is the one preferred over that one. We simply laid it out as it's been laid out there. And in terms of the mitigation measures, there was quite an extensive paper that accompanied those minutes, which has been, I can't remember if that's the final version or it came out a week or so later, I think, the final version, which laid out all of the mitigation measures that we thought were ones that should be looked at, which have been, I think, incorporated into the DFE advice. So we laid out that, and we absolutely recognised and have done for a long time that social distancing is very difficult to do in schools, and other measures are as well, but some, including things like ventilation, are important and need to be done properly as part of this.
Can I just, I think, Chair, and I think that a lot of this comes from a kind of slight misapprehension that SAGE kind of lists the government to do the following 15 exact things, and then the government either does or does not do those and deviates from. That's not actually what SAGE is supposed to do, and that's not what SAGE does do. It lays out broad principles, and ministers then have to incorporate them with everything else, including social impacts and educational impacts and economic impacts. So it's not a matter of SAGE sort of saying this is what government should do in minutiae. It's SAGE laying out the scientific basis, which is part of a decision making for a minister.
Thank you both, that's very helpful.
Thank you very much indeed. Carol Monaghan has a follow-up question before we go to Zara Sultana. Carol?
Yeah, thanks, Chair. I wonder if you could explain more clearly the reasons for the 5-week delay. I mean, I'm looking at government's website just now on the roadmap out of lockdown, and it says a minimum of 5 weeks between each step, 4 weeks for the scientific data to reflect changes in restrictions and to be analysed, followed by 1 week's advance notice of the restrictions that will be used. Now, I think we understand the reason why advance notice is required, but why 4 weeks for the gathering of data? We're seeing all the stream time data in terms of case numbers, hospital admissions and deaths. So why do we need 4 weeks?
Shall I go at that first, and then Christy may want to come in. Again, we've looked back, and the modelers and others have looked back and asked, when do they get reliable information? And again, just to restate some of the thinking behind this as to why it's the case. When you open something today, you don't instantaneously start to see an increase in infection. It takes days for people to be increasing their mixing contacts. You then got days before that becomes something that turns into an infection. You then see a growth of infections potentially over a period of a couple of weeks that you might be able to pick up. You won't see that trend instantly. You've then got to wait and see what effect that has, whether that's turning into hospitalisation. The retrospective analysis says that the earliest time at which there's confidence in the trend you're seeing is 3 weeks. That's the earliest, and that's quite a vulnerable early 3 weeks. A week to then make sure that you really understand what you're looking at was the assessment that then you can be much more robust about what you think is happening with the trends. And we've all seen the data. It jumps around at weekends, it jumps around up and down as people have other things going on that mean that a number may go up one day and down the next. It's pretty difficult just eyeballing it over a shorter period, and people will do that.
Sorry to interrupt, but that's why we use the 7-day rolling average rather than looking at the daily cases.
Yes, and that also isn't a precise estimate of which way things are going. So we think that the assessment is that it's going to take 3 weeks to have reliable data on which to make decisions as a minimum, and more likely it'll take a few days after that to get that into some sort of form. So the 4 weeks is the data analysis and ability to explain that so that ministers can make decisions. That's the reasoning behind that time frame.
And just to add one technical point, which is as the numbers get smaller, the data bounces around more. So actually the uncertainty gets greater.
Okay, and can I ask then about this additional week then? In Scotland we've done it differently. We've set out the date, and the dates will be confirmed a week before that, which still builds in the weeks, I suppose, preparation time for different sectors, but it means that there is an expectation there already if the data supports that. Was that not possible in England?
So I'm not sure. You're saying that at 4 weeks make an announcement? Is that what you're saying?
No. The different restrictions. There's 3 weeks between them, and we already know the roadmap in Scotland is also published with these dates. But the announcement will be made a week to 2 weeks before that, the opening up. It still gives the businesses time to prepare, still gives confidence in it, but it shortens that additional week that you've said we need in order for sectors to prepare to reopen.
Well, I think
this 5 weeks seems awful long.
Well, as I said, our advice is on how long it takes to get the data and to be confident as to what the data is saying, and that's the advice we've given. The decisions on what period is needed for government to then implement that with business is one for ministers. It's not a scientific question, I think.
Okay, thank you.
Thank you very much, Carol. Zara Sultana and then Andrew Griffith.
Thank you, Chair. My questions are aimed at Sir Patrick, but if Professor Whitty wants to come in, that's more than useful for me. In Wales and Scotland, pupils will be returning to school in a staggered start, with their devolved administration saying that they are following the scientific advice. So when parents in England look at what's happening in other parts of the UK, they're concerned if their kids are being put in more risky, unsafe environments with the Big Bang return. Do you think it's good to have consistency in policy across the UK, like, for example, on school reopenings?
Okay, I want to pick up on one thing in that, if I may, to reiterate what Chris said earlier on, just to make sure it is clear to people who may be listening to this. I know you will know this, but the risk to children is very, very low. This is a disease which disproportionately has its effects in older people, and children themselves are at very, very low risk from this. In terms of the consistency, SAGE is a body that brings together people from all of the devolved administrations, all of the science advisors and medical advisors that feed into the devolved administrations come to SAGE, and a lot of the information comes from there and then gets taken out to the devolved administrations. The process, as we said, of laying out that advice was to look at the impact or potential impact of schools opening with all the uncertainties around that, and then to look at what would happen in a single opening versus staggered. And in either case, you end up in the same place. You end up over a different timescale to get there. And again, you would need to allow enough time in any staggered opening to be able to measure what you do as you go along. So I think the advice that came in terms of what the science says was almost certainly the same across all of the devolves.
Thank you. SAGE advised that schools should go back into phased return to avoid a third wave, as well as other options. Scientific advice on this issue and on previous occasions in terms of advising the government to go into lockdown during the first and second wave, to not lift restrictions too early, to implement a circuit breaker lockdown in September, and against people mixing over Christmas. These pieces of advice have seemingly been ignored by the government. Do you agree that the government has a track record of ignoring scientific advice, or at least using it inconsistently?
Well, I think, as Chris said, I mean, our job is to lay out as clearly as we can what the science advice is, with all of the uncertainties, and there often are quite large uncertainties around that. And I think we've done that and make that as clear as we can and as public as we can, so you can see what the advice is that's being given and how it's being presented. Ministers clearly are the ones who have to make decisions on this, and will need to take into account many other factors when they do so, and that's what they do, and that's what is part of the process we live in order for decisions to ultimately be made and operationalised. So I think our advice is there for all to see. Our advice is clear. We've given it repeatedly and not always welcomed by all sorts of people, and when we give the advice from all sorts of different parts of the community, but we give it as we see it, and then of course it's up to others to try and interpret that with the other information that they have and the other priorities that they may have.
Thank you, Sir Patrick. Ministers always tell us that they are following scientific advice, but the government failed to consult SAGE on Eat Out to Help Out, and SAGE weren't informed about the return of university students until quite late, and then warned of a significant risk with the reopening of campuses. Do you think that the government understands the role of scientific advice in a pandemic?
Well, again, I mean, we meet as SAGE once or twice a week and have done so right from the beginning of the pandemic, and we look at all of the areas that we are either asked to look at or ones that we choose to look at. We have something, I can't remember exactly the number of subgroups, 15 or so subgroups who work round the clock, bringing in advice from everything from environmental monitoring through to behavioural science, modelling, clinical, other aspects. And they feed into SAGE, and we make all of our information in our papers public, and I think the government listens to that all the time. I mean, Chris and I are in meetings very frequently, giving the information, making sure people understand it. But, as this committee will understand very well, there are many other factors that are taken into account when decisions are ultimately made. And so it's not the case that SAGE, as Chris has just said, says, here is the answer, do this. What SAGE will do is say, this is our best assessment of what the science is telling us at the moment, and therefore what the options are and what the implications of those might be and what the uncertainties are that come around that. That is what our job is, to try and make sure that that is clear and understood. And it's my belief that in government they have heard, understood what we have said, And it's not that there's been a lack of understanding of what's been presented. We've made sure that that's presented, and therefore it's part of a more complex decision-making process. But Chris may want to add as well.
No, I mean, I think that anyone who's a minister would say that what this should be is scientifically informed policy, but and that's a subtle but important difference. The science is part of a decision-making process. It is not the full decision-making process in these kind of very big, societally very important decisions.
Zara?
And just finally, going forward and thinking of the future, we're going to have to live in a particular way for a long period of time with, future pandemics potentially and viruses and so forth. Do you think it's important to make sure that scientifically informed policy is the way we look at things going forward?
Well, as the Government Chief Scientific Advisor, my answer to that is yes in all domains.
Yes, and I'm the Chief Scientific Advisor in my own department, and I also think the answer is yes. But that's not that surprising. But we do actually, I think, very strongly believe that in very large areas, science advice may be the dominant area. In many more areas, it's an important contribution, and there are many areas where it's irrelevant. But science, where science is relevant, having very good science advice is very helpful. And I think, just to spare Patrick's blushes, we do have in the UK one of the best science advice systems in the world, Chief Scientific Advisor for government and then departmental Chief Scientific Advisors. And I think people should realise that is actually not typical. And it is something which I think we should use, and many of you either would have been ministers and will be ministers, and I hope you'll continue to use the science advice because it is critical to any decisions.
I may draw your attention, if I may, because you asked the question, and I completely agree with the way you framed it as science-informed policy. I may draw your attention to a publication that we put out about 2.5 years ago called the Science Capability Review about science need across the whole of government and how to strengthen it, and we are in the process of continuing to do that.
Wonderful, thank you so much.
Thank you, Zara. And just to emphasise that the fact that Sir Patrick and Professor Whitty are make regular appearances before this committee is comparatively unusual in international terms, and their scientific colleagues too, and we're very grateful for that. Zara was asking about schools. Perhaps Professor Whitty could just clear up a point of confusion that seems to have arisen in the last couple of days with students and pupils going back. If someone tests positive, if a child tests positive at school on a lateral flow test, and then subsequently tests negative with a PCR test, does the PCR test trump the lateral flow test, and can they continue their education?
The danger of me answering that question is that this is something where the Department of Education and PHE have hammered this out. And my exact memory of exactly where this is, the danger is I'll add to confusion, Chair. So rather than adding to confusion, I'm going to say I think that's laid out in Department of Education guidance. Okay, well, I think it will be helpful to clarify it, and perhaps when you go back, I mean, I've been having emails as a constituency MP, and I know my colleagues have. I think some clarity on that would be very helpful. Thank you. But I'm turning now to Andrew Griffith.
Good morning, Sir Patrick and Professor Whitty. Thank you, Chair. Science and research has been at the heart of all of the most successful parts of how we've dealt with this pandemic, most obviously the vaccine. But our next generation of current undergraduates are locked up in home in their parents' spare rooms rather than in our great academic institutions. Now, the government has promised to review this before the end of the Easter holidays, but could you just give me your advice, perhaps Professor Whitty, that if the case rate stays where you expect it to, would your advice support bringing back our undergraduates for the final term of this disrupted year with the social distancing precautions?
Well, as in a sense with the sage general advice, I'm going to give a general answer, but it's really for ministers to decide on exactly what happens. The thing about the university and further education sectors and higher education more widely is that it's a much more varied sort of structure than schools. I mean, schools are also varied, but not to the same degree. So the disadvantages from not being at university vary, or other higher education vary very substantially, depending, for example, on whether it's a practical course or not. And there is actually, prioritisation for people who are on courses which have a strong practical component, because you simply can't do that from home over the internet. They also vary, for example, in terms of under what environments people are living. Are they living in halls of residence? Are they living at home in multi-generational households, or whatever? There's a variety of different ways in which the higher education sector is very, very much more varied. So what the way that it's been laid out is to have a kind of an order of prioritisation for people to go back, which takes account primarily of how essential face-to-face teaching is, and then secondarily where people are on their educational journey through the higher education system. But I mean, all of us would want, at the point that it's possible, for people to go back to universities, not just for scientific things, but for all education, sciences, arts, practical courses of all sorts, because not only is that a very critical part of people's individual intellectual and other development, it's also, to go back to a repeated point, one of the great drivers of reducing disparity over generations. So I think that the reasons we would want people to go back to university are really clear, but at the same time, there are bits of university and higher education which can be done remotely, and whilst there's a very high risk, the prioritisation in education has to be primary schools, secondary schools, and the most practical bits.
But as that risk dissipates, there's nothing we're missing in terms of the risk of the 19 to 22-year-old cohort.
No, and I think the risk to those individuals from catching an infection, whilst probably not quite as low as for children, is very low. And so this is actually about the transmission in the wider community and just adding to the force of transmission at a time we're trying to drive rates right down. It's not because we're worried particularly about the risk to the students themselves. And I think one aside I'd like just to make is that we've had a big worry about this at the beginning of the autumn term for universities and higher education, further education. And there was a big surge of cases, and then due to the fantastic work of the higher education, university and other sectors, and also the extraordinary forbearance of the students, sticking to rules, the rates came right down. And if you look at, it's extraordinary reduction in rates over really quite a short period of time. So, I mean, it can be done in a safe way. It's not the kind of student experience that people, I think, read about or were imagining to some extent. And that, what we hope is people will be able to, in due course, go back to the kind of the full fat version. But it is, we have demonstrated, the higher education sector has demonstrated, that it can significantly reduce the risks. But at this point, whilst the rates are still very high, and I think we think of things as going down a very long way, but if you look at the ONS numbers, we still got about 1 in 250, slightly more than that actually, people have actually got COVID. So the rates are still very high, but coming down. We do hope they get down to a point when higher education becomes something which I think we all feel can probably be welcome. I don't know whether Patrick wants to add to that.
No, I think that's right, and I think the university did do a good job, and as Chris said, the students did as well. And if you look at the data from some of the universities, which are quite good genomic data, it suggests that actually the universities didn't cause much of a spread into the towns locally, but that may vary between universities. So the ones that have done it, you can't see much of a spread going on, and we know that certain things like halls of residences and so on are more risky for spread than individual houses. So there's some things that we know. The universities, I think, have been pretty good at managing all of this, and the students have been very good at sort of going along with it. And so I think there's a review going on to see when this can be brought back. But I'm with Chris, and I'm sure the students are looking forward to what he's described as the full fat version again at some point.
Well, thank you both for your answers, and hopefully as part of building a science-based superpower, we can get our undergraduates back to get that experience as quickly as possible.
Thank you. Just before I go to Mark Logan, just on this point of universities, the universities minister wrote to students on the 2nd of February and said that scientific advice remains that higher education teaching settings are very low risk, and I think you've repeated that assessment today. And given that the universities, as Professor Whitty said, did take steps to put in testing facilities, they've got their own labs, And given that 5 weeks is such a big chunk of the final term or term and a half for students, surely this is a good illustration of, if the data show that it's safe and proportionate in a low-risk setting with institutions that are capable of putting protections in place, isn't the cost of keeping students away from their lectures and sometimes for their final weeks of their university experience, isn't that disproportionate to the risk? Professor Whitty, please.
Well, I think, the first two points. The first of which is, in broad terms, I broadly agree with the kind of lead up to your question, and that's that I think we would all recognise. The second thing is we have still got very high rates of transmission, and we're having to make really have really difficult decisions as a society, final decisions finally being made on behalf of society by ministers, where all the things that are not being possible as a result of COVID are things we would want to be open for whole heaps of very strong reasons, and that's clearly a very strong reason. What has happened as of yesterday is that the roadmap laid out that practical higher education courses can start to reassemble, but all of us would hope that we can get to a stage as soon as possible that higher education is possible, just as we hope that a very large number of other areas of society will be able to open up, but we have to do it in a staged way. And every time you add something in one area, you're potentially going to have to take it off in another to achieve the same overall epidemiological impact. And this decision is finally for ministers.
All right.
Just because I think it's worth understanding where we are at the moment. The numbers as of last week anyway, were higher than they've been at any point from the beginning of May through to the end of September last year. So just to sort of frame it as to where we are, we're not in some sort of extremely low risk situation. We're where we were in that above where we were in any of that period, and as Chris said earlier on, take off from this point can lead to quite high numbers pretty quickly.
Thank you very much indeed. It's going to Mark Logan and then Graham Stringer, then Carol Monaghan.
Thank you, Chair, and it's good to see both Professor Whitty and Sir Patrick today, and thank you for everything that the science and medical communities are both doing. My questions are around border controls, and I was just wondering, what do you think is the best approach to limiting the importation of cases through border controls?
Well, the advice that we've given from very early on is that, and WHO have also said the same thing, which is that the border controls are most effective when the rates are low in your country and you're trying to stop them coming in from higher rates elsewhere. So that's where you have the biggest effect. Obviously, if rates are high in your country, stopping it from lower incidence countries, prevalence countries, isn't going to really make a difference. The second thing is that in order to stop any importation, you have to have completely rigorous border controls, which would stop everything coming in, and that is an extremely onerous requirement, but that is the only way you can stop things coming in completely. And even there, you won't stop them completely, but you will maximally reduce them, but that is a very, very onerous border restriction. Reducing entry through other measures and self-quarantine and so on for reducing the chance of coming in from places with high rates or high rates of variance will delay rather than stop. And those are the principles that underlie it. The WHO has made the same points. And clearly then there are policy decisions which people need to make off the back of that information.
And do you think, Sir Patrick, like in the cases over the last year, say Australia and China, a large part of their success in keeping the importation under control and the wider infection rates, is it because of that more onerous and perhaps more severe type of quarantining system that's put in place there?
Well, I'll take New Zealand as the example. New Zealand clearly has got a very, very rigorous border system and has got no cases or very few cases, and it maintains that through a very, very rigorous border system. And that's the approach that they've taken. Clearly, at some point, they're going to have to open up their border, and at that point, they will see an influx of infections. But that is that's the route that they've taken, and it shows that with no COVID, you can, if you seal yourself off effectively, prevent all but a few cases coming through. But that's one extreme of the position. But that's, I think, what they've done.
In the next few months, as we kind of move to open up international travel and looking to the summer months, I mean, what would your scientific suggestion be if we get our infection rates like down incredibly low and we have mass vaccination across the UK? Would you suggest that all people returning to the UK, or indeed those who haven't been vaccinated, for example, coming to the UK, should all go into hotel quarantining?
Well, again, we wouldn't make that sort of specific recommendation. It's not what we do. But I mean, I think our advice is very clear, which is that get out the vaccine as broadly as you can. And I think the approach that's been taken, driven, I think, by a very sensible public health requirement to get a single dose into people as quickly as you can, and then get the second dose a few weeks later to allow more people to get the first dose. That's the right thing. We've got to get the vaccination program rolled out as widely as we can. We need to keep our numbers down, and that's the really key thing. I think the focus on keeping our numbers down is the right thing to do. And it's worth remembering that the variants that people are concerned about are likely to arise everywhere. So although there are some that have come up in certain places, and largely they've been detected in countries which have got good sequencing capability, so there will definitely be other variants that simply haven't been detected because they'll be in other countries that aren't sequencing. And I would expect to see more variants emerge. And if you look at what's happened, there is a process of convergent evolution, which of course, members of this committee will be familiar with, which is that wherever we're seeing these changes, they look the same. So the virus is actually doing the same thing in different ways, acquiring certain mutations that it wants to acquire, largely for purposes of transmission, as far as you can tell. And this is something that means that we will see those being acquired in this country, and is again a reason to keep rates down as low as possible. So that's where I think we should focus our attention.
And just finally, so I mean, the implication of that, I mean, do you feel that we'll be able to stop new variants entering the UK?
I do not think we will stop new variants from emerging with this virus. It is what will happen. You can minimize the chance of it happening by keeping rates low, but just as the flu virus changes every year, so I would expect this virus to change over time, and that's what viruses do. They mutate, and then when they find a mutation that gives them some advantage, they'll hang on to it. At the moment, the advantage is largely on transmission. So most of the mutations that are occurring are ones that would give the virus some sort of transmission advantage. Once the world is vaccinated more, then there may be variants that come out that try to get around the immune problem, the immune response a bit more, and that will then lead to a need for new vaccine variation coming on maybe every year, every couple of years, we don't know.
Thank you. Professor Whitty, just anything to add to that?
No, I think that covers it very clearly.
Great, thank you. Thank you, Chair.
Thank you, Mark. Just to follow up on this, we had a conversation with Professor Sir John Bell, who was witness to the committee a few weeks ago on this point, and the question of border controls came up, and he was asked about New Zealand. And he replied, have you ever flown into Auckland, and have you ever flown into Heathrow? You're in a completely different world. I think it's unreasonable to think that the UK is going to look like New Zealand. It's a very different situation. Given the interconnectedness, given the flights in and out in normal circumstances to the UK, should we be looking at measures internally to control any incursion pattern rather than seeking to seal ourselves off from the rest of the world. Perhaps Professor Sir Patrick first.
Well, as I said, I think our focus needs to be on reducing the levels we have here. That is the key point to keep things under control. I think as levels come down, test, trace, and isolate becomes increasingly important. Cluster identification, making sure that we understand where there are outbreaks and how to deal with them. And of course, the vaccine is going to make a huge difference to all of this. I do not think that zero COVID is possible. I think there's nothing to suggest that this virus will go away, at least in any time soon. It's going to be there circulating. It may be a winter virus that comes back over winters with increasing infection rates during that period. I don't think zero COVID is possible, and I think it's going to be very difficult for any country to maintain complete absence of this long term, because at some point countries have to open up borders.
Well, Deputy Dame Angela McLean said that it was a fallacy to think that we know where new variants will arise. The implication is that they arise in all countries, or can arise in all countries. So is it sensible, is it effective to have a red list of countries for which there are very extreme restrictions, when there could well be variants in lots of other countries that we simply don't know about?
Well, as I've said, I think variants will arise everywhere, including in this country. They're an inevitable part of this. And then if you take the second principle, which is that border controls are most effective when you've got low incidence here and higher incidence or prevalence somewhere else, then you can apply that equally to variants as well. So if you knew somewhere that had sort of 80% of a certain variant circulating, it's a much higher probability you will import it from that country than a country that's got 1% or 0.5% of that variant. So there's some logic in thinking about where you've got the highest prevalence of either the virus overall or a particular variant. But I don't think we should dream that you can stop these things coming in, or indeed evolving within domestic virus transmission.
There are countries where there simply isn't enough sequencing to know whether there are variants that might worry us if we knew about it. Is that not the case?
That is the case.
Thank you. Graham String.
Professor Woolhouse told this committee that the risk of transmission outdoors was very low indeed, yet the policy of restricting people going outdoors is having really quite severe implications for civil liberties. I can understand why Merseyside police prefer going to Formby Beach rather than chasing drug gangs in Liverpool. But when there has been no real evidence, when there are beaches in Formby, Brighton, all around the country have been crowded, of an increase in infection, wouldn't it be sensible to advise to get rid of this policy? And if I can sort of roll my two questions into one, what is the scientific basis of the rule of six?
Who's that to?
Oh, sorry, I'm not sure. Whoever would give me the best answer, I suppose.
Sir Patrick first.
Well, outdoors is absolutely lower risk than indoors, but it's not zero risk, as Chris said, and it depends what you do outdoors. So, clearly people in very close physical contact outdoors, people passing around things where you can transmit from hand to implement to hand to face, is not zero risk. So it's not zero risk, but it is definitely lower risk than indoors. And that has been something that we've been concerned about right from the very beginning. Indeed, right at the beginning, our concern was indoor spread, particularly in closed environments where you've got lots of people, poor ventilation, ability to spread easily in pubs and other things were a concern right at the beginning, much more so than outdoor gatherings. And that remains the case, that outdoor looks like lower risk. And that's why opening up outdoors is coming before opening up indoors, and is the order in which we would agree with. You can see that when levels are very high, then clearly you have a risk of transmission, and as levels come down, the risk of transmission outdoors goes down even further. So that's where we are. So I agree that it's much lower. I don't think it's zero. but it's lower risk.
So saying it's not zero, I think we can all agree there's virtually nothing in life that is zero risk. But the empirical evidence, when there have been crowded beaches, is that there is no spike, there's no evidence that that has led in those areas to increased infection. Yet there are consequences to people's civil liberties of them not allowing, and to their health, of not allowing them to go into parks and onto beaches. And if I can repeat the second part of the question, what is the scientific basis of the rule of 6?
Well, I'll have a go at this, and then Chris may want to come in. I think we've said previously that the rule of 6 is not something that's got some scientific absolutism to it. It is a policy decision based on minimising the number of people interacting, and that is the case. That obviously, the more people you have interacting, the higher the chance of there being some spread. And I reiterate that our view has always been, and is clear, I think, in the SAGE papers, that outdoor is much lower risk than indoors, but it's not completely risk-free. And it is the case that I think it's difficult to see how things like large beach gatherings and so on, and indeed I think the same was the case in a protest march in New York, where they didn't really see any spikes after that. So it is lower risk, but of course the other thing that can happen with outdoor events and so on is when indoor things are also open, that you start to get people congregating indoors around that, and that can increase risk. But outdoors itself is lower risk. Chris, do you want to answer that?
No, completely agree.
Okay. Thank you, Graham. Carol Monaghan.
Thank you, Chair. First of all, just following on from that, Sir Patrick, there's a report in today's Times that the Children's Minister has said that face masks will not be enforced in secondary schools, will not be made mandatory for students in classrooms. Are you comfortable with that?
What we suggested on actually is quite an important point, is you come out of lockdown that these things become more useful. So if you go back to coming out of the first lockdown, that's when we said that masks become more useful, because you start to get further interaction. So I think the advice is that in secondary school children, you can see this across Europe, many countries have taken the same position. Some have gone down to primary schools, which I think is not workable, that it's advisable for those children to wear masks. At the moment, there'll be a data review and see where we are and see where the numbers are. And as numbers come right down, these things can get looked at again. But that's the advice at the moment. In terms of the translation of that advice into recommendations, that's for ministers to decide how to do that.
Okay, thank you. Now, Professor Whitty, you've previously drawn upon flu as an analogy for ministers assessing acceptable risk. One thing we've tried to tease out in this committee on a number of occasions is what level of death is actually acceptable. So can you give us any indication of what level of risk is acceptable?
You've commented on this before.
I have commented on this before, and I mean, my view remains the same, and it remains the same, I think, as pretty well everyone, which is the idea we're going to get zero deaths from this is unlikely, to the point of not really be worth considering as a policy option. There are going to be deaths from this. There's no doubt about this, unfortunately. The question about how much society is prepared to take as a kind of to reduce that risk is actually a societal question, and therefore a decision for ministers and Parliament, and in the devolved authorities and nations, obviously, for their ministers and Parliament. And the reason for saying that is, just take the example of flu in a different way, which is not comparing the death rate. This year, we have had almost no deaths from flu. Flu has virtually disappeared because flu has got a lower rate of transmission than COVID. So if you get COVID right down, flu goes away. Now, would we want to go forward in a situation where we say, right, now we know how to deal with flu, we're going to have every winter is going to be like this winter, and then we'll get no flu deaths? That's a societal question. That's a choice, essentially. And that is a choice for society as a whole, reflected through ministers and parliament. And so, I don't think this is a situation where a doctor like me or a scientist like Patrick and me, Patrick's also a doctor, should be saying this is what it should be. I think what we should say is these are the possibilities, here are the upsides, here are the downsides. And remembering that there are significant downsides from a health perspective, leaving aside anything else, to things like lockdowns and all the things that are going on. So these are not, even if you just take a health perspective, there are risks and benefits on both sides of the equation. And obviously, when you lead to wider societal issues, societal choices, seeing family, economy, there are other factors to bring into account as well. These are very difficult things to balance off. And this seems to me very, very much, excuse me, a societal question.
Thank you. So, given that it's up to ministers and wider society to decide what this acceptable risk is, have you been given any indication of what sort of level this is?
Well, I think at this stage, the clear indication is that everybody thinks that the risk from COVID is far too high. And that's the reason people in all 4 nations are taking the decisions they're taking at the moment. The question about how far down the slope we can go, and then towards the end where it's discretionary, what are the things that people wish to do as society to push it even further down? That we haven't really got to that point, I think, in the decision-making process for any of the 4 nations at the moment. I think the one thing I would, though, be very much caution against is people thinking that we can go to a zero COVID approach. I completely agree with Sir Patrick's point on this. That is not a realistic goal. If by zero you actually mean zero. Now, some people are reinterpreting zero to mean very low. Very low, yes, we absolutely are all wanting to go to very, very low. But very low and zero are, to me as a scientist, 2 rather different things.
Yeah, we rather assume zero actually means zero,
yeah,
not low. Seems like a reasonable assessment.
Yeah, low we absolutely all want to go for.
Okay, we've had evidence in this committee from people that suggest that we should be taking a much stronger approach. I mean, Professor Devi Schrader argued that our public health support approach should be more akin to the measles, and the UK should be aiming to suppress and eliminate COVID through vaccines, mass testing and supported isolation. And Dr. Stephen Griffin raised concerns because he said the more we learn to live with this virus would give it more opportunities to mutate, and actually was not in our best interest. It was far better for us to, or I think what he said was to maintain significant prevalence would be unwise at best. Do you have any comments on those 2 pieces of evidence we heard?
Well, I think both people I have huge respect for, but let's take the measles example. So measles is a disease where if you catch it once, you never catch it again, basically. So it's a single infection, gives you a complete protection for life. And the vaccine basically does the same thing. That's not at all similar to COVID. Second thing is that measles is a disease where the great majority of the risk is in children, and therefore the ethics strongly support vaccinating children at a very early age. Measles is a much more dangerous disease in childhood than I think it is widely understood to be. It is in some countries it can have up to 5% mortality, much lower in the UK, but still has significant risks of encephalitis and brain damage and many other problems. But so therefore vaccinating children is absolutely the right thing to do. In COVID, we got a situation, and therefore you can get the whole population vaccinated with a vaccination program that will protect them for life. That is completely different from COVID, where firstly, the vaccine is not a complete protection and natural infection is not a complete protection. And secondly, because children relatively are spared, we're much more cautious about vaccinating children because the ethics of vaccinating children to protect adults is quite complicated. And we're going to have that discussion at some point as a society. but it's not the same as measles, where you vaccinate children to protect children, and then they're protected for life. And then you can end up in the situation where you have almost complete population immunity. But even with measles, with this incredibly effective vaccine, and where you can actually, you can get to these very, very high levels, including down in children. People have talked about eliminating measles for a very long time, and countries come in and out of elimination, but it hasn't been achieved yet for any significant period of time, and that's the real risk. If by elimination you mean 0 cases transmitted in a clear and reasonably large geographical area, which is how I would define it, we are nowhere near eradication on measles, for example. So I think, people, that comparison, whilst I understand the points being made, I think is quite a difficult one to sustain. The general principle that we should try and get the rates absolutely as low as possible, completely agree. And, if I could choose to magic this disease away, I think there's sometimes an implication that somehow people who argue you can't have 0 cases want COVID to continue. I would love COVID magically to disappear, but I'm an infectious disease epidemiologist. This is something I've thought about quite a lot over many infections. Getting rid of infectious diseases that have a significant asymptomatic spread, highly transmissible across all ages, respiratory transmission all around the world, that's quite a tall order. So I think it is very important to, if we get to the point where it is at such low levels, we finally can say, oh, we're very, very close to elimination, let's give it a go, fine. But we are an incredibly long way away from that one now. At this point, we should be concentrating all our efforts on getting it down as low as we possibly can, and then see where we go. And all of us want to get to the point where there is as low cases as possible. And if we can get to 0, fine. But I think that the very, very few scientists who have looked at this actually think getting to 0 is a realistic option. All of us think getting to very low rates is a realistic option, and that's what we should be aiming for.
Okay, so at the lowest level of our current COVID alert system can only be reached when there's no cases in the UK. So do we need to be revising this if a 0 COVID approach is not possible?
Well, I think when we get down to the point where we're at the next lowest level, where there's very, very low levels and we're not getting significant importation, and we will get potentially to that point with vaccination in the UK and globally. And it is very important we see this as everyone's problem globally as well as just a UK problem. We can't just solve the problem here and then have done with it. Then I think that debate is a very right one to have, but we are quite a long way away from there now in all 4 nations and across Europe. So I think we should be humble in the face of a very, very dangerous and highly prevalent virus at this point.
Okay, thank you. I suppose that is something that us as a committee and the government will need to come back to then at another date. And Sir Patrick, if I could just direct my final question to you. The government has talked about reopening of international travel from the 17th of May. Are you comfortable with that? Was that a recommendation of yours?
Well, again, we don't make recommendations on specific actions like that. And what we've given advice on is the relative measures, the relative importance of different approaches to border controls. We've published that evidence, and we've given a very clear recommendation that the keeping levels low in this country is what we should really be aiming for as a priority. But we don't give advice on specific actions.
And are you expecting? Are you happy with that particular piece of government advice? So.
Well, I think travel will reopen as inevitably at some point. Travel will reopen, and clearly, as more countries become vaccinated, and it reiterates the point that the fighting of this virus is a global thing. It's not a national thing, it's a global thing, and therefore vaccines need to get out to other countries as well. As more countries become vaccinated, and as we get the ability to understand how much transmission reduction is reduced by vaccination, it makes a freer movement across countries much more possible again. And that's clearly what needs to happen at some point. Whether or not that's with certification or whatever, we'll see. But I think at some point travel has to reopen, and it has to be done in a way that's safe and can be detected in terms of variants and so on, which speaks to a screening program which has to be global.
Thank you. I think you're maybe avoiding the subject slightly. We know that other countries are way behind us in terms of vaccination. So really it's about this date, which is in about 2 months' time, of the 17th of May, and whether that's a sensible date or not.
Well, I will answer again. I've been very clear that we are going to have to measure as we go along, and we don't know. So I'm not.
Thank you, Sir Patrick.
The dates are really only times when we look at data.
Thank you, Sir Patrick, and thank you, Professor Whitty.
Thank you, Carol. Dawn Butler, then Catherine Fletcher.
Thank you very much, Chair. Professor Whitty, I understand that a zero COVID strategy isn't about zero COVID. It's about the approach taken and how the government acts to try and eliminate as much as possible the risk of COVID. So, for instance, having unclear messaging isn't a zero COVID strategy. A zero COVID strategy would mean you'd have the clearest messaging possible so that people follow all the instructions and directions, so they're compelled to do that. Like if we educate people in regards to being outside as opposed to being inside, mitigating the risk that we spoke about earlier. That is a zero COVID strategy. So the strategy is different from saying we want zero COVID. Is that not correct?
Well, I have to admit that as a scientist, for me, zero means zero. So if you're saying I want a zero COVID strategy, what you're saying is I want zero COVID cases. Now, you can say that. What I'm just saying is I don't think that's a realistic option. Now, if people say, well, I don't mean zero, I mean another number, fine, but then put a different number on it. I completely agree with your thesis, though, which is clear messaging, trying to be simple, trying to actually make the points as explicit as possible. And to go back to our previous discussion, trying to make sure that every community is reached by messaging in an appropriate way. Those are absolutely central. So I think, I'm not disagreeing with you, except I'm just making a very specific point about the term zero, which has a meaning in science, and I think we should stick to that meaning.
Fair point. I didn't create the meaning, but fair point. The other question I have is on test and trace. Do you think that the resources spent on test and trace should be spent on other interventions? Would it have a better outcome?
Well, I think resource questions I always avoid answering just on a matter of principle, because that's really a question for ministers. But I will say a bit generally about the benefit of test and trace, fully accepting there are multiple other things we have to do. It has to be seen as part of a wide sweep of different things. And within test and trace, there are kind of at least 3 different elements which have different purposes and different advantages. One of them, which is the one that I interact with on a daily basis very closely, is the information gathering bit. The Joint Biosecurity Centre, and the UK now has an incredibly sophisticated system across all 4 nations for gathering data, some of its ONS data, some of its test and trace data, so that we actually know where we're going. And this goes back to the initial premise of this whole discussion, which is that is the data which will help us decide, is it safe to move forward to the next stages? So all the data that's collected in very considerable detail by a variety of different routes, which you can then triangulate, is really critical to making safe and sensible policy decisions. Then there's a very important part of the testing and tracing system, which is around testing people who are symptomatic and might have this, so that they isolate if they've actually got COVID. And that is really critical, and there's really clear evidence that's a very, very important part of it. But it also means that people who don't have COVID can go about their daily business once they've been cleared from that point of view. And then the final bit is the case finding and contact isolation. And that's also an important part of it, and will become an increasingly large part as we get down to much lower numbers. So I've said right from the beginning, because it is a kind of basic principle of public health, epidemiology management, that case finding and isolation and contact isolation has a much smaller part to play when you've got incredibly high numbers, simply for practical reasons as much as anything else. As we get down the numbers curve, an increasingly high proportion of the heavy lifting can be taken by that. So our hope is that simple interventions like washing hands, face masks where it's appropriate, test and trace, and above all vaccines together will provide a lot of the really heavy lifting for keeping the virus rate down for much of the remainder of the year once we got it down from this initial lockdown. So I think you know, you can see the different components in different ways.
Yeah, I mean, I agree, but for people to self-isolate, that comes with its own complications in regards to can they afford to, etc. But my last question to both of you, please, is there's obviously a gap in regards to the science and then what the politicians say. What has been your biggest frustration? Professor Whitty, do you want to say?
If I'm perfectly honest, and this is not aimed at politicians either in government or not in government, is a general statement, it's when what we think we have said, or I certainly think I've said clearly, is then misrepresented to the general public. And the reason is that that causes confusion. It's back to your previous point. It's absolutely critical that we give clear messaging. Now, sometimes I give unclear messaging. It's my fault that I'm just not communicating clearly. But obviously, you also have situations where people misrepresent what you're saying for whatever reason, and that confuses the general public. And that really is not helping in a general pandemic. So my frustration is actually when science advice given publicly is in a sense miscommunicated. But I, you know, absolutely would take my own share of the blame for that, because sometimes that is because I simply haven't communicated well enough myself. So I'm not trying to point fingers at other people.
I hear that. Is there an example you could give us?
I'm not going to give examples because that would be unfair.
I thought
I'm just making the general point.
Fair enough. And Sir Patrick.
Well, Chris has said exactly what I would say there, and I'm also not going to give an example because that's the example that would then become exactly used described. So I shan't do it. But the other sort of frustration in the whole thing, which I think it is not to do with politicians, or it's to do with we've at every stage have to deal with imperfect information. There's uncertainty, and what we're trying to do is to express what we know and what we don't know and what the uncertainties are around that. And that's going to continue to be the case. And I think that uncertainty is what we all need to bear in mind. And it doesn't mean that the science isn't valuable. It's incredibly valuable because it bounds around that uncertainty, but it's not a precise answer. It is a best information at the moment.
Thank you.
Thank you both very much. Thank you, Chair.
Thank you very much indeed. Just to follow up Dawn's questions on test and trace, perhaps to Sir Patrick, SAGE in the autumn thought that the test and trace system was not making a significant contribution to reducing the R rate. Is it now?
Well, test and trace, I think, is working very well at the moment, and testing is obviously, as Chris said, incredibly important for the information we have to monitor this. So I think there's a very good testing system in place now, which reaches a high proportion of people who are positive, and that's going to be increasingly important as we come to very low levels. And the reason, and again, this is something that is worth just being clear, what was said when SAGE made a comment about test, trace and isolate, it was that at very high prevalence levels, contact tracing and isolation becomes progressively less important because the disease is everywhere and you can't do it. So what becomes important then is obviously isolation and taking people out of being able to circulate. As prevalence comes down, test, trace and isolate, and it's worth remembering the isolate bit remains very important, becomes increasingly important to try and stop the cases that are there from being able to spread it. So I would anticipate the impact of test, trace and isolation is actually going to become even more important over these next few months as we go into hopefully lower levels and ability to then get back to a form of normality.
The testing system, what about the tracing system? What's your assessment of that at the moment?
Well, I think that the examples that we've seen recently of the tracing system being able to identify cases of new variants and track them down even when forms have been lost is impressive. And I think we've got a much stronger system than we had certainly at the beginning, and it's taken a long time, of course, to get it there because it's a complicated thing to do. But I think it's working pretty well, and I think that tracing is going to be important, particularly so-called backward contact tracing, when you ask the question, where might this person have got it from, and can I trace where they have got it, so you can identify clusters. And that's what's going to be important, I suspect, as we go forward.
The roadmap in terms of unlocking, as we've discussed extensively this morning, depends on a number of assessments on the effectiveness of the vaccine, its rollout, the spread of transmission. How important has test and trace been in your advice to government as to the pace of unlocking?
Well, what the modelling has assumed is that there are baseline measures which will be effective as things are unlocked. And one of those is test, trace and isolate. Others include things like hand hygiene, include things like mask wearing and so on up to a certain point. And so those baseline measures are assumed to take some of the lifting going forward as we unlock.
The Test, Trace and Isolate organisation has made an estimate of its impact on R, which I think from memory extends to up to 0.8. Have you assessed their assessment?
Well, we've done various assessments over the course of the last 8 months or so of impact of isolation, testing, tracing. I don't have all the figures at the top of my head, but we've published several things on that over the period. We haven't looked specifically at the work that they've done, but and I think the impact of test, trace, and isolate does vary depending on the state of the epidemic. As I say, at very high prevalence, it's very difficult for that to make a big impact.
But in terms of the assessment that they presented to this committee and to the Public Accounts Committee, and was part of their business case for quite considerable sums of public money, over 25 billion that they're spending, SAGE and its subgroups haven't validated that, or am I wrong?
We haven't been asked as SAGE, and it would be a slightly strange thing for us to be asked to do, to validate that for that purpose. I don't know. I suspect they have been involved, but I don't know which of the modelling groups may have been involved in helping that. They're quite closely linked in to JBC and other parts of test, trace and isolate, so I wouldn't be at all surprised if some of the modelling groups have been involved in that.
A final member to ask questions before we have some brief supplementaries is Catherine Fletcher.
Thank you, Chair. Gentlemen, thanks hugely. Always a pleasure. And to be schooled and to learn from your magnificence. Now, my dad's a fan of yours, and he for many years has participated in the UK Biobank study, longitudinal study, based in a wonderful facility in South Manchester in Cheadle. And he recently got a lateral flow antibody test through the post, which I assisted in drawing his blood in at the weekend, and happy to confirm that his first dose AstraZeneca vaccination has produced not only a strong IgM response, but also a strong IgG response. Now, many moons ago, back last year, antibody testing, so for the uninitiated, have you had it and are you immune, versus the antigen testing of have you got it now, was, that antibody testing was hailed as one of the ways that we recover and return to normal life from the pandemic. Given that we're now testing lateral flow antibody tests, perhaps, Sir Patrick, you can talk about what role they've got to play moving forward.
Yes, so first of all, I should declare that I was on the board of Biobank for a number of years, and so I know that organisation well, and I'm strongly supportive of the work that they're doing, actually, which I think is going to be important. You're quite right that the antibody levels are now increasing across the population, particularly, of course, in the above 60-year-olds who've been vaccinated. And I was just looking at some data this morning, and we're getting to quite decent levels of antibody there, and that speaks to the question of, you know, what do you do about using that for some form of certification and so on. And I think the Royal Society has produced a very good document on that with 12 things that need to be considered when one thinks about certification, ranging from what are you trying to use it for, because clearly what vaccination or an antibody positive test tells you is that you may be protected personally. It doesn't tell you that you can't spread it to somebody else. That's different from an antigen test, which might tell you you don't have it today, and therefore you might not spread it today, but you might, of course, catch it tomorrow. So there are different tests. You need to think about how durable those results are. You need to think about how they can be protected for you as the individual, how verifiable they are. And I thought the 12 tests that the Royal Society laid out were a good way of thinking about this as governments think about how they want to consider any form of certification around this, including issues around equity and inequalities that might arise as part of that. And we, you know, had a lot on that today, rightly, because, you know, this is a disease which feeds off inequality and feeds inequality, and we need to watch out for that as we go to any new measures. But I think it's likely that we'll have some form of international agreement around how to use these things for travel.
Almost test to travel coming through a postbox to you soon. No, thank you. It's an exciting development, and he was genuinely excited. I think maybe slightly more broadly, just to close. You know, I have an aunt and uncle also in South Manchester who have been giving blood on a regular basis to the Oxford studies, and there is a huge groundswell of not only interest in, but value of and understanding of what we can do as the British public to participate in scientific research. So, you know, whilst we're still locked down and we're still just looking at that light at the end of the tunnel that's coming, what would you say to the British public about participating in the life sciences, whatever you are and wherever you are? Perhaps Sir Patrick and then Professor Whitty?
Yeah. I mean, first of all, I'd say a big thank you, because it's been fantastic. And actually the response of people to the scientific studies has been really spectacular. If you take something like the recovery study, it was over, I think it was over 11 or 12% of people, possibly even higher, who were in hospital were part of that study. That is fantastic and exactly what we should be aiming for. When we don't know the answer, as we didn't for those drug studies, and indeed for many forms of research by definition, making sure that we can encourage people to get into trials is the way to get answers. And we've seen that really dramatically across this. I mean, the UK has been brilliant in the studies that have been done that have come up with answers, what works, and as importantly, what doesn't work. So we don't end up giving things to people that don't work. So I'm absolutely excited about the fact that the British public has been so great at taking part in these studies, and they're so interested in doing so. And I hope that will be one of our lasting legacies from this, that we will be a country that continues to really have widespread public participation in science, and that we have a system for getting answers to those questions that we don't know as a result.
I'm just going to, in a sense, echo to some extent what Patrick said. I completely agree. Massive thanks to all those who've been involved, not just in trials, but also in the observational studies, which have been very important to our understanding. And I mean, just three additional points, one of which is to say thank you to your family, who are clearly a part of the scientific effort, but be actually very typical.
Very far from the getting enthusiastic about studies tree, unfortunately.
Yeah. But we're getting very close. I mean, one of my other roles is I run some research, which actually does a lot of which is the structure for a lot of the clinical research. We're getting very close to the point where almost 1 million people in the UK have taken part in clinical studies, either observational or trials, and that includes trials of drugs, where the UK has really taken a leading role, trials of vaccines, where we've obviously the AZ is the exemplar, but also we've trialed other drugs as well, but also the big observational studies, the SAREN study in healthcare workers, the COSIN study, which has actually looked at a lot of people who got severe disease, and in fact, going back to some of the earlier discussion, really helped to tease out some of these issues around risks for people of different ethnic groups. So the extraordinary volunteer spirit that people have shown, the patients in hospitals, the volunteers of trials, and also doctors, nurses, other healthcare workers who on top of their day jobs have enrolled people into studies, made sure it's safe for them to do it, done all of the work. because that's the way that we've actually managed to really accelerate the knowledge in this disease. And the UK has done more than probably almost any other country per head of population because of that volunteer spirit from the population and the healthcare staff. And my final point is, if you look around the UK, all 4 nations, it's not just the teaching hospitals. We're talking about the district general hospitals, the general practices, healthcare workers in more community settings, people working in nursing and residential homes. So this is across all of society that this is being taken part, and it's a real gift to the future. That's the way we're going to get on top of this virus, and indeed it's an offering in a sense from the UK to the whole of the world. So it's basically a very long-winded way of saying thank you.
Thank you, Catherine. Just some brief supplementaries. One from Graham Stringer.
Brief, well, I hope the brief supplementaries. We're coming up to, in fact, we've probably passed it for a number of people, the 12 weeks since the first vaccinations. When the commitment to give those people a second vaccination comes around, will that lead to a significant drop in first vaccinations, and do you have numbers for that? Sorry, Professor Whitty.
Well, I think that so the first thing is that because we did the delayed second dose, we've been able to vaccinate a much larger percentage of the population. And as Patrick has said, I think that has proved to be a sensible decision. It was obviously a decision based on data, but it was indirect data, and I think now in retrospect the data are backing up that that was a reasonable, safe and sensible decision, because it's led to a much larger proportion. Now we are revaccinating people, and that has now started, but it'll really start to take off, because if you think back, 12 weeks ago was back in December, and that was the point when the vaccination program was really beginning to take off. So of course this is going to follow. So we're going to start seeing the numbers of people getting their second vaccines really starting to move up quite rapidly now. And the most recent data on that show over 1 million people have had a second vaccine now, but we're expecting the numbers significantly to go up. Now, of course, the problem we've always had, and this is the reason we delayed the second dose, is limitation on supply. But at this point in time, our expectation is we'll be able to manage that second vaccination, which is really critical people do it. And I really want to stress to people, if you've got family members who are thinking about doing it, really encourage them to do it, because that's how you get full and long-lived protection. The bigger it is from the first one, but you still get significant additional protection from the second vaccine, and probably more long-lived protection. So really critical people have that. But there should be enough vaccine supply additionally to roll out the first vaccine to the larger part of the population, who still haven't had one vaccine. Of course, there's a large numbers of caveats to that, because vaccine supply is always subject to all the problems of any kind of drug supply. But at this point in time, our expectation is we can both, over the next few weeks, continue to do the second vaccination, but additionally do first vaccinations as well. Of course, it won't go quite the same way as if you were only doing one vaccination, but we do expect to be able to do both.
Thank you. Surge testing, we've not really touched on it, but I looked on the website this morning. It said the objective of surge testing was to better understand the virus and to monitor and suppress the spread of the coronavirus. I think looking on the website, there were 28 surge testing projects, there may be more by now. Have those objectives been met, and are there any other objectives? Has it been an effective programme? Professor Whitty, sorry.
Well, I think with all of the various forms of testing, the first thing to say is that you're not taking someone from a high risk to zero risk. What you're aiming to do is to reduce risk by identifying people who have got infections, who don't know they've got infections in these surge testing models, and then making sure that they can then isolate, knowing that they've got the virus. The assessments of them in places like Liverpool have, in a sense, been mixed in both positive and negative ways. The positive assessments, and I think it's well worth looking at this, and the colleagues in Liverpool have really been very good at assessing this and designing it in a very good way, the University of Liverpool and others. Positively, significant numbers of people have been identified who otherwise would not have been identified. The downside on this is that, as always, there's what's called the inverse pair law, which is where there's less ability to do this with strong support in areas of higher deprivation, where in fact the risks are, as we were discussing earlier in the session, potentially greater. So this is not a panacea at all, but it is a useful addition to other measures, provided it's properly targeted, and when we're doing it in a new way, provided it's properly assessed. And of course, there are different sorts of surge testing. So additionally, there's the surge testing, for example, that's done around variants of concern, and that's for a slightly different reason. That's to pick up or identify the size of the problem, and to make sure that we can reduce the risks that things like the South African variant are widely spread. So there are a variety of reasons for doing it, the variety of mechanisms. None of them are perfect, but our expectation is that most of them, certainly some of them, probably most of them, have had a significant, useful, additional effect on top of other activities, but they're not a panacea.
Last one to Professor Vallance. You were both extraordinarily helpful at the start of this epidemic in opening up both the membership and the minutes of SAGE, so that we could all understand what was going on and who was involved in the process. Unfortunately, the NHS England haven't been as open with the information that might enable us to understand what's going on. Local NHS trusts are really controlled and can't put out information without the say-so from the centre, which often doesn't come. Trying to get the number of cancelled elective operations, trying to get the number of cancelled emergency operations is very difficult. And we also now have the Biosecurity Centre, which isn't as open as SAGE. It's a request to both of you, but I'd like Professor Vallance to answer. Openness in this epidemic is vital. I think you agree on that. Can you put pressure on all the bodies, NHS England, Biosecurity Centre, to put out as much information as they have?
I'm in favour of making sure that as much information as possible is made public, and I've made that point repeatedly and will continue to do so.
And will you put pressure on to do that? That's your view. You both have very influential positions to put pressure on these organisations.
Well, I certainly do ask for the areas that are relevant to what we're doing, that we make data available as we can. I clearly can't be responsible across the whole of the other parts of government for this, but I think, yes, we ask for that, and I will continue to ask for it and continue to make the point that I think openness is the right way to deal with this, and it allows other people to look at the data, analyse it, draw interpretations. It's a very important part of the scientific process.
Thank you, Graham. And just to reinforce what Graham said to Sir Patrick, you've been absolutely instrumental in changing the procedures of SAGE to make the papers open from the outset. And that was a personal initiative at the request of the committee, and we're very grateful for that. It's been very important to the scrutiny and learning from the pandemic. Finally, Erin Bell.
Thank you, Chair, and thank you again, gentlemen. As a computer programmer, I always found that treating 0 as a number equal to 0 was pretty useful as well to avoid any unexpected behaviours. So I think we're as one on that. But the roadmap said that all limits on social contact will be removed eventually. Which restrictions, if any, would be needed after the 21st of June date? Sir Patrick first.
Well, I don't know, because as I think, tried to say that we need to look at what we measure every 5 weeks and see where we are. So it rather depends on where we are in the epidemic. I'll answer sort of slightly more helpfully though by saying that I think that next winter, I wouldn't be surprised if we have to keep some sorts of things in place as numbers go up again. I certainly think we should keep the hand hygiene going. I certainly think we should keep test and trace in position so that we can monitor what's going on. And I think it's possible that there'll be situations where masks need to be worn in certain crowded situations if numbers go up next winter. But it's very dependent on data and how this goes.
But no social distancing, just masks.
Well, it's possible that there's some form of, I think two things. First of all, I think there will be some innate social distancing just because of behavioural change. People will actually behave slightly differently, which will create some of that. And we don't know how much more may be needed over the course of next winter. Next winter won't look like this winter, but it won't, there will still be cases, there will be increase in numbers, I suspect, and we should expect there to be some sort of pressure next winter, but nothing like we've seen over the course of this winter would be my view.
And if we come to masks, would you envisage that would be something that's largely voluntary and encouraged rather than compulsory next winter? Because it seems to me that we will be in a very different place, and it's much like it is how, it's up to people whether they go out and risk catching the flu. Are we not in an analogous situation potentially next winter with COVID?
Well, if we're in that position, if vaccines are as effective as they look as though they are, and we've got great coverage and this is controllable, clearly you don't need as many things to be there, and you could release many of them. If that's not the situation, and something has happened, new variants, whatever it might be, that changes it, then we'll have to see where we are and respond accordingly. So I think it's just too early to say how this will look.
Thank you. And on that point, the Prime Minister has obviously indicated that the point of this roadmap is to do things irreversibly. Under what circumstances could you envisage measures being reintroduced? Is it simply the variant situation, or are there any other reasons you might think we do need to reintroduce measures in the United Kingdom?
Well, the aim of measuring as you go along is to make sure that you take the right steps when you've got the information. I don't think we yet know how this is going to play out longer term, but I think, and Chris may want to comment, but I think our view is that this becomes progressively less of a problem as we go forward. It doesn't mean it's going to be zero problem over next winter. I think there will be cases, and so reintroduction of measures is entirely dependent upon the course of the pandemic and things like if there's a new variant that completely escapes immunity, which I think is unlikely. I think more likely the vaccines will have an effect. They already do have an effect on most of the variants. The higher the immune response, the better it covers some of the other variants as well. Variant vaccines are being produced, which will have an effect. So I think it's all pointed in the right direction, but I think nobody can say with certainty that this is finished, and we're certainly not out of the woods yet, even on this wave.
Thank you, Sir Patrick. Professor Whitty?
I start with a very healthy regard for the pragmatism of the people of the United Kingdom, all four nations. People know that winter is when seasonal viruses tend to be worse, and our expectation is there'll be surges in winter. People know this is a new virus about which we do not know full amounts. I don't think anybody's expecting us to be able to predict exactly what we needed, when, where, and how. I think we'll take it as it comes. None of us want to have unnecessary measures at all. Equally, none of us want just to not have measures just on a point of principle when it's obvious we need them. So I think the sensible thing is we just take it as it comes.
Thank you both very much. It's been very helpful.
And doesn't it follow from that, Professor Whitty, that the right demeanour is actually to be ready, to be poised to take measures if they're necessary? And actually, is this whole doctrine of irreversibility in one way actually not the right stance that we should be taking? Shouldn't we be preparing ourselves to be poised to spring to take action, perhaps in the winter if necessary?
Well, I mean, I absolutely not want to speak for the Prime Minister, but I think what he means by irreversibility, and I think what most people understand it to mean, is that in the foreseeable future, we don't go down a path which we have a very high chance of having to reverse almost immediately out of again. I don't think anybody is trying to say, well, we have absolute certainty about exactly where we'll be over the entirety of the next 5 years. I don't think anyone in the country is expecting that, and I certainly am not. I doubt any of the committee are. So I think irreversibility is to do with what we can see in the next period. There are some uncertainties ahead, and we'll just have to deal with them as they come.
Thank you. We've talked a lot about dates and putting forward some of the questions that will arise in the debate around this in the Chamber of the House of Commons as to the timetable. And you've set out why these 5-week intervals are appropriate. Perhaps just coming at it from the other side, how would you assess the risk of not being able to make the best before dates, as it were?
Well, by definition, I don't know, which is why we want to measure. Currently, things are looking good. They're headed in the right direction. Numbers are coming down quite well. Very pleased to see death rates coming down steeply. So it's all headed in the right direction. And if that continues, then that's a very good path to be able to do what's in the roadmap. Clearly, if there's some unexpected upswing, and Chris has already alluded to the fact that there's an increase in numbers being seen in some countries in Europe, which, if you were to take a historical view over the past year, we've tended to follow that when it happens. Hopefully it won't happen this time because of vaccines, but we need to be vigilant.
Thank you. So do you regard is your central expectation that the dates that are published in the roadmap will be the dates that the various unlockings will happen?
Well, my expectation is that the dates in the roadmap are the dates at which we will have data that we will feed into ministers to make decisions.
Thank you very much indeed. You've been very generous with your time and your expertise and experience. As I said at the beginning, this is a session in which we've tried to put some of the questions that we know are on the minds of other members of Parliament. There are 11 of us on this committee, the 650 members of Parliament. They will be debated in the chamber of the House of Commons when these measures come for approval and the debate around that approval. So you've done us a great service by answering a lot of the questions that are on people's minds, and for that and for your great efforts throughout this pandemic, we're very grateful. That concludes this meeting of the committee. Order, order.
Thank you very much.
Committee, 9th of March 2021.